physicians in prescribing antibiotic for acute respiratory infections in primary care. It's a very hot topic nowadays because using overprescribing antibiotic and resistance to antibiotics is a big issue, not just in Vietnam but all over the world. So, Thảo Hằng, take it away.
Hello everyone. Today I'm very excited to be here with all of you, and I'm also really nervous because I'm the first person who present in Journal Club, and I'm very sorry for my late for today. So now I will start now. The topic we are talking today is clinician-targeted interventions to influence antibiotic prescribing behavior for acute respiratory infections in primary care, and this is an overview of systematic reviews. First of all, I'd like to tell you a little about the acute respiratory infections. As you know, ARIs is a popular disease in our community. It is a common community-acquired disease, and it may interfere with normal breathing and cause many discomfort symptoms for especially for children and older adults. And ARIs can be classified as two groups: upper respiratory tract infection and lower respiratory tract infection. The acute upper respiratory infections are the disease related to nasal cavity, pharynx, and larynx, such as someone like common cold, pharyngitis, and epiglottitis, or otitis media. And the acute lower respiratory infections is some disease related to trachea, primary bronchial, and lungs. Some disease of this group are laryngitis, bronchitis, or pneumonia. And let's look at the diagram. As you can see, maybe RSV is the most common cause of ARIs, and we also see that not all ARIs are caused by bacteria. So, and antibiotics is especially used to cure bacteria. So the big questions for our doctors is antibiotic for ARIs should or should not. And today antibiotics resistance is the worldwide health threat, and many science and doctors and are doing something to always keep antibiotics working, and many interventions are expected to reduce antibiotic resistance. Now we will go. That is the reason why I chose this article, and in this review, the main questions update is what is the effect of clinician-targeted interventions on antibiotics prescribing behavior for ARIs in primary care. And the study design is the synthetic of evidence from systematic reviews and which are looking at interventions to reduce antibiotic resistance. The methods of this review is composed concurrent and randomized controlled trials, which evaluate the effects of any clinician-focused interventions on antibiotic prescribing behavior in primary care. The trial turned to this review must meet selection criteria, and we will see the study flow diagram. As you can see, there are so many records identified in June 2016 through database searching, but at the end, it just has A reviews included in the overview. And the quality of the evidence in this review is assessed by the GRADE system. The GRADE system composed of four grades for high, moderate, low, and very low to assess the quality of evidence. And you can see the RCT or systematic review is in the high quality of evidence, and we have some criteria to low and to high the quality of evidence in our review. Now we will go to the results of the review. As you can see, in this review, the scientists focus on three interventions, which are CRP, point of care testing, and shared decision making, and Procalcitonin guided management in two settings: general practice and in ED, emergency department. And so with the results show that CRP testing or shared decision making or Procalcitonin guided management broadly reduce antibiotic prescribing behavior of doctors in general practice, and only Procalcitonin guided management is demonstrated to properly reduce antibiotic prescribing in emergency department. Next, we go next, when compared to the usual care, CRP testing and or shared decision making make little or no difference to the usual care, but the Procalcitonin guided management can properly reduce treatment failure in emergency department. And we can see only the Procalcitonin guided management can have this ability to reduce the treatment failure for ARIs in emergency department. And so the conclusion of this review is we have some moderate quality evidence, and this shows that shared decision making or CRP testing did not affect reconsultations between doctor and patients, and only procalcitonin guided treatment reduced treatment failure in emergency care, but not in general practice. And to sum up on this review, we have we will answer the main questions of the review I mentioned above is in primary care, CRP testing, shared decision making, and procalcitonin guided management can reduce antibiotic prescribing for ARIs. So in the past of discussions, I want to tell you about the questions Dr. Min taught recently. And the first question is, can we believe in this review? And I think we can definitely believe in this review because it is an overview of ACTs or randomized controlled trials, and the evidence we have a qualified moderate according to the grade system. And what should we do in general practice? And in my opinion, I think that we should carefully prescribe antibiotic for any disease, not especially for ARIs. And in emergency department, we can use procalcitonin to guide antibiotic prescribing management for ARIs. But some disadvantage of this review is that nearly all trials they take are undertaken in high-income countries, so it is not general in many countries like Vietnam or some country which is not on higher income. And in this review, they didn't mention about the information of the cost. So I think it is difficult for a doctor to make a decision use procalcitonin or CRP or shared decision making. The tools are not antibiotic for our patients. And now that's on my presentation, and my presentation is not good, and I think it is have some mistake and maybe make you confused, and I hope that I can bring you some information and receive your comments, and thank you for listening.
Okay, thank you very much, Hảo Hằng, for the very first presentations today. The very first thing I would like to tell you is, you may say sorry before being late, but don't say sorry about your presentations. You do your best. You may not get to the expectation people may looking forward to you yet, but don't say sorry, okay? You should say that, well, if I'm here to answer all the questions you may have for me, and I can ask other or my supervisor or the specialist here to help answer whatever question I may not be able to answer, something like that. But don't say sorry, okay? From now on, not just for you, but other presenter in the future. Don't say sorry. Ask for help, but don't say sorry. nothing for you to be sorry. Okay, and actually you're doing pretty good. I'm quite impressed. Okay, but I have some comments, but I leave the floor for people to give their feedback to you first, and also practice giving feedback is also a way to learn. So don't feel shy, don't feel worried. Just say what you think honestly. We're here to learn. We're not here to make fun of anyone. We're not here to show off that we know more than other. No, don't. This is not the place for that. So yeah, please honestly share what you think about your friend and ask questions to help others learn. All right, who first?
Well, so now since I'm one of the older members, I'll start first.
Okay.
Okay, so I think the presentation is considered as your first time was done very well. I like the format, the slide easy to see, its structure short and concise, so it's really good. The content of the presentation is also good. So there's like main point that present clearly. As for the only thing is there's a lot of mistake in pronunciation, which I think we can fix easily. Yeah, that about the presentation. I do have some questions, but I'll leave it at the later to ask. Okay.
Okay, it's good. So yeah, I got the message here that the group chat here. Yung Leung said that your presentations was good. Great job, Yung Leung, for giving feedback to our friend. But can you tell her at least one thing that you think she's doing good? What you like in her presentations? Yung Leung? Hello? Yung Leung, can you hear me? Hello? Yung Leung?
Okay, I'm here.
Okay.
And the thing that I especially like about her presentation is the content, especially when she gave the second slide about and give people a review of respiratory infection.
Okay. Anything else?
I think, I think she gave good reason to introduce the topic of interest here. That is, not all ARIs, acute respiratory infections, are caused by bacteria. That is a good point to start. I think so.
Okay. Okay, it's very good. Yeah, so it's good to give support to our friends by saying you're doing great jobs. It's very good, but it's even more helpful if you can point out things that your friend doing good, so that they can reinforce the good things, so that your friends and others know that, okay, that's the good thing to do, that's the good way to do. And also point out what area that your friends can improve. Yeah, be more specific. We learn from that. Okay, that's very good. Let me see. Let me pick on the old guys first. Tuấn, Trần, and Tuyền Nguyễn. Any feedback for your friends here? Hướng Trần first. Yeah, at least tell one thing that you like about the presentation.
Oh, sorry, I have no idea.
Okay then. All right. And Tuyển, you cannot say no idea. You need to say something. Anything.
Yeah. I think her presentation so interesting. She speak fluently and clearly.
Okay. Yeah, just feedback for your feedback. You should feedback directly to your friends. So it says, yeah, how's your presentation? It's not her presentation, even though, yeah, it's my questions asking you. I pick on you, but you give feedback to your friends. So your presentations, okay? And yeah, I agree with you. Hảo Hằng is, yeah, your presentations, yeah, exceeds my expectations, my goals set out for you today. You follow the format. You spend time not just get information from the summary, but also from the article itself. You format the slides very clear, easy for people to follow, and yeah, a few pronunciations, but of course it's minor things. We can fix those, but it's easy to follow. That's the most important thing, and that's great. You get what we are looking for this very first journal club presentation. Now to the next step, we talk about the presentation, the English. Now about the content. I know it's the secondary goal for today, but anyone have any questions? I know that Hướng Trần, she's have some question for you. So Hướng Trần, what's your question?
Hi Thảo, I'm really like the way you present the ideas, because I have no difficulty understanding what you say. Like I don't have to make any clarifying questions, so that's the best thing that I like. So my question comes from the fact that I didn't read through the full text. So there's some piece of information that I'm not sure about. So just take these questions like I ask for your help, for your clarification. So there's two questions. The first one related to the results. If you want, you can move to the result slide for better illustration. Thanks. Yeah. So the variable that the author demonstrates here is rate ratio, odds ratio, and risk difference. So as I know, the odds ratio, it comes from because this is not a case control study, so it may come from the logistic regression techniques that produce this kind of measure instead of risk ratio. But basically, it's quite the same mathematic reasons. But when I say odds ratio, and I think of what can I whether I can believe that that number. So I wonder if you can give me a real number, like the proportion of antibiotics prescribing, like the rates of antibiotic prescribing in any of the reviews used in this meta-analysis. So because if the rate is a popular outcome, like it is more than 10%, so it may introduce a big difference in the rate ratio and the odds ratio, and here maybe the odds ratio is less than the real effect. You know what I mean, like the real effect size. So can you give me that number in the rates of antibiotic prescription? Is the first question. So the second question is, I'm not quite sure about the intervention called shared decision. So what they actually mean when they say shared decision? So can I apply this to my medical practice? So I just wonder that.
Okay, yeah, so while Thảo and prepare to answer the questions, yeah, it's a very common activities after you present the article or present any talk. The audience will ask questions, and yeah, you should, if you're not already an expert in that area, you should write down the questions so that you know what this question is about, so you won't forget. And also you still can ask question back to clarify the question if any part that you not quite understand, and if you need help from any extra person, a specialist or friends or whoever, then feel free to do so. But you're supposed to be the expert in this area because you know about the topic. Okay, Han, you understand the question? First, do you understand the question that your friend asked you? Han, you still there? Oops, she closed the slide, so I don't know if she's still there. Let me check the list. Han, oh, you. Hello, Han. Hello, you still there?
Hello.
Yeah.
Yeah, I'm still there. Yeah, there are little trouble with the internet.
Okay.
Yeah. Yeah, I can understand what Hương mentions, and I'm trying to find you the detailed information in the full text. Yeah.
Yeah. Again, this review article, they get the results from many different study, and they put together to prove the point they want to make. So yeah, it's not the randomized control study itself. So sometimes it's the result is hiding somewhere in the review, and sometimes certain specific information you may need to read the original article to get that particular information. So yeah, I don't remember. I see it in the article itself, but let me just also check it together with Thảo Hằng. And yeah, the question is very valid. The OR or odds ratio, or the odds ratio and the relative risk, sometimes it look big, sometimes it look quite impressive. But if the raw value, the absolute risk is tiny, then it's like we always say, it have like statistical significance, but this may not have the real clinical significance when we apply it on real life practice. And about the other questions, Let me see about the other questions. Refresh my mind. What you say in the other questions?
Share decision, like a
Share
description
decisions.
of.
Oh, okay. Yeah, share decisions. Yeah. Han, can you answer that question first? While I try to look for the answer for the other question for you. What they meant by share decisions?
Oh yeah. Share decision making. In this full test, they define it as the process of enabling a health professional and patient to make a joint decision about management based on the best available evidence and the patient's values
Hello.
frequency.
Okay. You all can hear.
Hello?
You all can hear
Yeah,
how? It's got cut off.
I'm here.
It's got cut off a little bit. So can you repeat your answers one more time?
Oh yeah. According to the full test, they define the shared decision making is the process of enabling a health professional and patients to make a joint decision about management based on the best available evidence and
Okay. Yeah, it's got cut off by
the
the end.
patient's values. Yeah.
Okay. You understand what she tried to answer you?
So basically, I get it that if I prescribe antibiotics to my patient, it means both the patient and I agree on the use of it, right?
Yeah. According to my knowledge, I think that in shared decision making, you will show your patients that antibiotics or some test is useful for them with the best evidence, and we analyze to them the advantages and disadvantages, and so they will make a decision that they will use antibiotic or not.
So can I understand that my patient will help me to lower my probability of prescribing antibiotics for them? Like they help me to, yeah.
Yeah, according to this article, they show that it is an intervention to clinician targeted intervention to reduce antibiotic prescribing.
Yeah, let me write that and see. Yeah, just like someone says, shared decision making is, yeah, basically instead of you tell the patient, hey, do this, no question asked, or the patient tell you, I need antibiotic, and you prescribe to them, it's now involve a little bit discussions, talking, tell the patient, hey, that's what I found on you. You may have some cough, but for example, there's no fever, no crackle in your lungs. Antibiotics is, yeah, may not be working for you because likely it's virals, and it may increase the risk of like resistance. Yeah, basically just give information, and two of you can come to the conclusions. I know we don't have a lot of time, especially in Vietnam, to discuss with the patient the reason we do things, and sometimes it's faster just to write the antibiotic rather than talk to the patients. So basically, this meant that way, give the patients the informations, discuss with them what you find out, and what is the best practice in that case, and come to the conclusion. So basically, if you have time to talk to the patients, if the patient understand the reason you do things for them and it's the standard practice, then yeah, likely they they together we do the right thing. So basically like that. So we need time to talk to the patient, which we not always have enough. Not just in Vietnam, in over here also. Even though we have more time over here for sure. Okay. Yeah, I may pencil out the questions to try to look up the information to answer that for Hương, but I could not find it right now to get that answer for you. But from my personal experience, and you may well know the prevalence of prescribing antibiotic is quite significant. So it's not just 1, 2, 3%. It's likely 20, 40, 50%, or sometimes more. So look at that information, and I'll let you know. Okay. Okay. Let me see any. So, anyone have any questions? It's all quiet. Jerry, you have any questions?
Hello, Min. Hi.
Yeah, hi, and then,
yeah, okay. Could I speak something? Okay. How
yeah,
many
sure.
minutes you have?
We really honored to have you here with us. I don't know anyone know about Dr. Dinh Nguyen. Yeah, he's one of the how should I say, one of the pillar, one of the main persons in VietMD that helping a lot of people, a lot of students here. So we're really honored to have him here, spend some time with us. So okay. Yeah.
Okay, that's okay. Just make it short. Okay. Now, first, I just have a general idea because I came in the middle of presentation, so sorry that I am say sorry here. Really, okay. I cannot say anything about the contents of the presentation, but I just looked at the article. So you see that anytime, okay, say sorry about that. Anytime when you look at the article, you have to answer 4 questions because it's a PICO framework. Big P is the population.
PICO.
Yes, okay. Population, that is which article talk about. So this article talk about the acute respiratory infection population. But this one is a very big one because they divide into 2 here. One is primary care and the one is regular care. Okay, and in that population, they don't divide into which group too. Like it's like a pediatric group or the geriatric groups or something like the age and the gender. So first one, the article not limited clearly what kind of population they talk about. They talk very general. Okay. The second question is intervention. So his clear-cut intervention is antibiotics. That's correct. Because use antibiotics or not use antibiotics. And the third question is a comparison or compare. Okay. So here, that's my problem when I read articles, because here they combine too much thing. Okay, first one they combine the C protein, the C reactive protein testing, and then they combine with a shared decision making, and then they combine with procalcitonin. So 3 factors in one article, and this article is not original one. This one is like a systemic review. We know that in the literature, we have the original literature, And then you have secondary literature, that is a systemic review like Cochrane's library that you already talked in the presentation. And then this one on the top of Cochrane's library. So you see, it's, when an article, you combine too many parameters there, it's very complex and it's become blur. Okay? Even at the conclusion, I can't believe that the conclusion from them, because if you look at the table, it's not very clear cut here too. Okay, and then so the last question is the outcome. The outcome, not sure 100% when I read that article. So which one is the most important? If you ask, that is a procalcitonin test, or CRP test, or shared decision making. So according to Hang Trần Đặng Hằng, so she make a conclusion that the procalcitonin is the best one. But I'm not very persuaded with that conclusion. Okay, that's also my feeling, so my opinion. Anyway, about the table, we need some people very good at statistics. I'm not very good at all. Explain more and make it clear cut, because all the article, you know, the main concentration that is on the table. The table of the article talks all and explain all, but up to now, I'm not very clear cut about those meaning from the table. Thank you.
Okay, thank you, Andin. So Thảo, you think you have some answer for that questions? How you understand about the question, and you have any answer for the question that Dr. Din raised for us here?
According to my knowledge, I think the first questions about the first questions Dr. Nguyen mentioned is about what is this review talk about, and this talk about the interventions which can reduce antibiotic prescribing of clinician, and the questions the second questions is about the design of the study, and to be honest, I'm confused when I read the full text of this article, because it is a systematic review, and I don't know what does it mean. They list a lot of CRCTs, and they conclusion in one sentence that CRP or procalcitonin or shared decision making is probably reduced antibiotic prescribing, and I exactly don't know why they can conclude at that, because I am not good at statistics. But I just read and take the main reason from the full text and the conclusion. To be honest, I think I didn't deeply understand this article. Yeah.
Okay. Any other? Yeah, I think there's another one also read about this article, right? I don't know if she's here. today. Anyone have any idea or any feedback for the questions Dr. Din just raised here?
I think his questions, Dr. Din's question is very interesting to me. And when I look at the table, I also ask myself that if I were the doctor, so which intervention I'd like to choose for my patient, for my practice. So when I look at the result table, for me, maybe intuitively, I will think that CRP will be my first choice, because the results, the measure they put out here is rate ratio. And for me, rate ratio compared to odds ratio or adjusted odds ratio is quite reliable. The other two interventions, shared decision making, there's a mixture, or procalcitonin guided management, they use odds ratio or a mixture of rate ratio and odds ratio. So as I can see in the shared decision making, the odds ratio looks a little bit more impressive than the rate ratio, and I'm putting a question. I'm quite doubtful that maybe it's the effect of using odds ratio for a very common proportion, like the proportion of antibiotic prescribing. It maybe is a common issue. So like Dr. Min said, it may be 20-30%. Overall, it's more than 10% in medical literature. They consider an outcome with more than 10% of happening is quite common. So I'm quite doubtful about the real effects, the effect size, the difference between implementing this intervention or not using it. So for me, CRP may sound the most reliable.
Okay. Yeah, so I'm no statisticians over here, but yeah, and then exactly it's one of the questions I pose in the group to see what kind of study or what kind of method used in this study. It's not like meta-analysis, but it's like a little one more layer on top of that. And actually the intervention is not to answer the questions whether RCT is whether procalcitonin is good. The goal of this study is not to answer the RCT is good or procalcitonin CRP is good, procalcitonin is good, or shared decision is one step above that. What they want is what factor, so they put all together and try to pick out which factors is really affect the prescribing decision of the physician. So yeah, I agree. It's quite an ambitious goal. I don't know that the design of the study is valid or appropriate. I hope it does, but it's just take a lot of information together and then figure out amongst many other factors. I think they come down to 3. CMLI is working by looking at different study. So yeah, I think it could be 3 different review. Maybe one review is the shared decision making, help doctor decrease overprescribing antibiotics. This other review is CRP, help doctor doing that, and maybe another review is procalcitonin, help ER doctor doing that, and this one just lump them all together and come out with hey, these three factors affect the prescribing behavior of the physician. So that's what I think they are doing. We may write down this question to ask Dr. Long and Dr. Vinh to give more feedback about that later on. That's what one thing that this journal club is interesting about. We may have questions and we may keep asking experts after that. So that's what I think about what they did on this study about the method. So can we believe the result? I think if the method is valid, no, not the method is valid. If each of the tests is appropriately done and the RCTs on the original study is properly done, then the results seem like significantly different. So the interventions in the original study make the significant difference. If we believe that, then seem like we can use the shared decision-making, CRP, or procalcitonin in the appropriate populations. So procalcitonin they mentioned about in ED patients, the other in primary care setting. So again, the it's quite ambitious goal. So when we talk about that, it's become a bit vague. But hopefully, I think you understand what they trying to do here. So I didn't. This help answer some of your questions from what I understand. I think you agree with that, or you still not really convinced?
I just want to tell you something about when you're reading an article. Never trust them total 100%.
Definitely.
Yes, okay. And I give you some trick. Okay, I'm not a very good reader, but there's some trick there. First one, you have to look at the title. You see, okay. When I look at that title, I see, like Dr. Mindo said, so ambitious. You see, why they combine too many factors into one question and not very clear cut? Because you cannot compare the test and the decision making, because the test is is very subjective. Objective. Meanwhile, decision making is very subjective. So you compare some factors from objective to subjective. That's flawed right away in the title. Okay. Number two, you see the review method. Okay. There's 3 points you have to look at it. The title, the method, and the table. So you see the review method. That one it's look like it's not good as a systemic review too. Okay, because original article is very good one. You can criticize on it. Okay, and then systemic review. Not every systemic review is good, because right now we trust Gottran's library. Okay, but you can see that some other systemic reviews they don't do well. Okay, so sometimes that one is like on the top of the other systemic review. So I am very doubt about that one. And then the table. Sorry, I don't understand the table much. But say they compare like that, I really unhappy why they compare like that, and they put so much varieties in that table. So in science, you should make clear cut. You don't want to make like a gray area between those comparison. It's not good at all. So with an article, we have to be care about that. Some article very good, and some article we have to find out which one is not good, And sometimes I myself, if I look at article, I will throw it away because I don't trust it at the beginning too. So that's the reason I. Okay, thanks.
Okay, yeah, and then yeah, I'm not expert in this area either, but I'm not thrown away, and then I still read it. And
I'm sorry, no, that's just a learning. Okay, we learn how to. Okay, Dr. Min, when you put that one, it's very good for us to learn it because we read it and we keep critical thinking. That's it. Okay, it's anyway, it's a very good lesson for us. Okay, to look at it because where the reason why I came today. Because I'm very interesting to listen to the expert of statistics to explain for me the table. Because I'm so, and I'm so a lot of question about that table. Okay, that's the reason why.
Yeah, so for this summary like this, normally they're trying to condense a lot of information in one table. So it's sometimes quite confusing. And I totally understand if the physicians following following about the study about prescribing antibiotic, then they may come to they have some idea or may come to conclusion for themselves about those like shared decision making or using CRP or Procalcitonin. They may come to conclusion by themselves already based on different meta-analysis that this article tries to put them all together. If people following this subject, they may already know about those interventions, and they may either already use it or decide not to use it because it's not really convincing. So this one just to put them together and repackage it and present it again. It's good in the sense that it helped them all together. So that's one of the reasons I'll choose this article for us to see. It's also good that just like Dean said, the method is quite complicated. That's why I also hope that we can bring it over to our specialists in the group to get some answer about this. I'll also trust the Cochrane review, Cochrane database, and also the ACP. They tend to pick certain good important article to present to us. So I hope we still learn something about this one, not just disregard everything. But
hello. Oh, sorry. Okay, I just make something wrong there. I don't say that not it's not throw away. It's just a funny talk. Okay, we learn a lot from this article. Honestly, we learn a lot because we can see that what the way that people do and see that it's good or it's not good. We still learn something because like before when I read in that article, I have to go and I look at it again with a C-reactive protein. What is it? And what is the current information or something about procalcitonin? So through the article, I learned a lot. Honestly, I learned a lot today from you and from the article. So I just say that a little bit like a funny just a joke. Actually, I really spent a lot of time to read that article and look and search internet to look around to see what is good for us. Okay. Thanks,
No,
Nick.
yeah, I understand. And then, yeah, if other small other articles I just happen to stumble upon, and with that big and ambitious, I may just do like you say, may just disregard it. But this one is for us to learn. And actually, you raised also a very interesting point in whether about the tests. How can we what can we do about the test? Whether they put the test out here, seem like it's very valid, very clear cut, and this positive or negative give us the answer or make us make decisions. But actually, it's not it's not that clear. Just like Thảo point out in her discussions, it's mainly in like high-income country, and to be honest, it's not like in standard practice, even here in the U.S. in my practice yet. And I have a friend. He's a specialist in lab. He's head of the lab in the Hoa Hao. It's in Vietnam right now, and he's deal with all this thing all day long. And he told me that the point of care test for CRP and Procalcitonin is not that reliable itself at this point of time. So now we go all the way around. We come back to the very beginning, to the starting point. This test, if that is working, if it's good, then it may give some information for the provider for the physician to make decisions. But what if the test is not that good? What if the test is not that reliable? Then yeah, we're in a difficult situation right here. Unfortunately, we don't have him today to have him talk directly to us about his experience, his knowledge about this. But yeah, I asked him about that earlier this week, and that's what he wanted to share with us. Yeah, the point of care test is not that great. Just like we cannot base on treating patient with diabetes with just one simple point of care blood sugar. Hopefully in the future it's become more reliable. Hopefully it's